Tonight is unique. This randomly we open up one of the lessons when we're kind of as either to bring in, try to get previous CCVR participants back on, joining a CCVR course, letting people who have signed up for the next launch get to kind of see what it's like to be in a coaching call. And then some people are just interested in kind of seeing what CCVR is about or hearing what the topic is. So in the past, I think even twice we've picked vision. There's such a big interest in vision. And on this one, we picked BPPV. So you should have the handout for tonight's call. We'll start this out on a regular basis. I'll, go over some updates. We'll review the assignment, and then bunch of questions were sent in, and then we'll open up the floor. So Annie, thank you. You may see Annie's picture there, her video, she's typing in. So I'm going to take advantage of this opportunity and put Annie on the spot. So Annie is going to be taking the lead with the next launch on the coaching calls in the CCVR. And so it's kind of like a passing on, I don't know if it's passing on the torch. We're on a relay team. We're running track. And we're running lifelong learning track. It's a really long distance. And so I'm just ready to pass the baton. But I'll be involved. I think it would be great to get some new insights in. I've been teaching this, not alone. Obviously, it's being involved in the CCVR. It's a lot of other faculty, but just like I learned with patients, I learned with all the participants in CCVR, and they each launch make this better and better. And so Annie's going to be leading the coaching calls with the next one. I'll be in the background, I guess, helping with monitor assignments and being on the coaching calls as well. So you can just all welcome Annie, and I really look forward to it. I did add a couple of articles to supporting materials. Remember, supporting materials is not mandatory. Those are it's additional information. I do have an updated BPPV assessment and treatment in there. The assessment really just goes over the different tests and then the treatments. It doesn't go into deep explanation of showing them. And so those are, things that you have access to in videos, or if you're not in CCVR and you're a member of 360 NeuroHealth, in the premium membership, you can have access to assessments and treatments there. And then the other thing I was thinking is, tonight I'm going to be going over reviewing some of the newer maneuvers or concepts. When this was first recorded, even since that time, there's been several new maneuvers. When I went under it wasn't the Emory certification, it was before it was Emory, it was in Florida. And when I went there, we basically did the epley, and we treated posterior and with the epley, and then the horizontal was the roll. And then we thought, well, with anterior canal, it never happens, and maybe we do a deep epley, or maybe we do a reverse epley because it's treating the other side. And now, there's so many maneuvers, and so you get to kind of choose which one that you like. Before I do want to go back, and so just about 50% of you have responded to, will you attend the lab virtually, like in person or virtually? And you can see here right now, we've got 65% virtually and about 35% saying that you'll be here in person. I'm excited about those of you that can come in person. But again, we've only got about 50% who have responded. We are going to do something different this year. And Molly's on the call, Molly Runquist, and she's super excited. She's going to come in and attend in person, but we will do the day we do the in person. We're also going to do an online version with the people that are here in person. And so we'll have people here helping with labs, and then we'll have someone on an online who will break out, and you can attend that day as well. So I'll follow up with that in next week's coaching call, and we'll get started. So I'm going to move some little windows out so I can actually read this. 72-year-old male, I'm not going to go and just read this line by line, but this was the case number 1 in the BPPV. Upon rising the next morning, it happened again. It didn't stop, lasted for 2 hours, called 911, taken to the emergency department, nausea, vomiting. Given medication, felt bad all day, kept for overnight observation, still was having some unsteadiness and positional vertigo, and then gave a brief finding about his examination, and then asked the 3 questions. And again, I did not obviously pick all the responses and just randomly picked a few. So, question number 1, based on the presentation, what's the most likely diagnosis or diagnoses? And it was pretty agreed upon that this person could have BPPV, and that it was probably maybe, following another event. He was not as mobile, and so, what would be your next steps during the visit? What other clinical tests would bring further insight? And this is going to be based on, we have physicians in the group. We have a physical therapist, physiotherapist. We have audiologist. And so what might be the next thing is going to vary upon, your environment and what you're used to, kind of evaluation you're used to performing. So we get the Epley, we get the Samant, we get the GANS maneuver. There's definitely a lot of different maneuvers that can be done here. And so I just kind of highlighted some of those different answers. It was noted that research supports vitamin D and calcium supplementation can help reduce recurrence. One of the things we always get is, what about allergies? The largest study about BPPV prevention is more on vitamin D, the use of vitamin D supplementation. We do see a higher recurrence here in the clinic during barometric pressure changes, especially those with barometric pressure related migraines. And we do know there's a higher incidence of BPPV with those who have migraines or Meniere's disease. And we do see a higher recurrence with allergies. And the literature does show there may be a higher occurrence during high pollen season. It was mentioned that we may do the bow and lean to specify which side may be involved, and we're going to talk about that. So I think there was, with the time that I started looking at some of these answers, there were, over 60 responses. So I really appreciate your participation in that. So what I want to do, because this always comes up, this didn't come up this came up in a CCVR, a direct message question, as I'm confused about the quick reference nystagmus guide. And that was given in lesson 2, the quick reference guide, where we talked about key characteristics of peripheral and central. It also talks about pattern of nystagmus. And this quick reference nystagmus guide is due to the acute onset of vertigo and which canal may be involved. It is not a chart used for BPPV. And that chart sometimes is confusing because if you look here, you see, okay, horizontal canal, it beats away from the affected side. In most instances, if we have a right hypofunction, we're going to get that left beating nystagmus. You'll see anterior canal is the superior vestibular nerve where it says upbeat and torsional, beating away from the side of the lesion. This is not BPPV nystagmus. This is based on the canals and what extra ocular muscles eye muscles that they innervate. And remember, the vestibular system drives the slow phase. So if you want to type in, how do we define nystagmus? When we're talking about, when we see nystagmus, how do we define it by how? By the fast phase. Excellent. It's the easiest to see is the fast phase. But when we talk about the vestibular pathways and how they talk to the eye muscles, the vestibular system drives the slow phase. And that's why this can be super, uber confusing. And I'm going to go back up and get a question here. With there being a higher incidence of BPPV in those with migraine, are you aware of any studies noting decreased incidence of BPPV in the population with CoQ10, riboflavin, magnesium, often recommended? I mean, that's a good question, you know. So I think I'm not aware of any specific studies of migraine sufferers when it's stable versus unstable. So that's a great question. If anyone out there is aware of a study, please post it. That's a great question. I'm not aware of any specific study that's looked at stable versus unstable vestibular migraines. Okay, so here, just a reminder, this is about neural asymmetry. So when I have an acute vestibular syndrome and if my right is shut down, even at rest, in the very acute phases, I'm getting excitation over here and it's going to cause the eyes to beat away. That is different than BPPV. Because this is what I was referring to. I know there's a lot on this slide, but the semicircular canal excitatory influences, that's what this is. This is about the excitatory. This drives the slow phase. So if we're thinking just excitatory, the posterior canal on the ipsilateral side is going to be the superior oblique. And on the contralateral side, it's going to be the inferior rectus. So if we think about what those muscles do, they're primary and secondary. So let's say on my right side is excitatory, is the superior oblique, and on the contralateral is the inferior rectus. And we think about what those muscle actions, what their primary and secondary actions do. We're like, well, in a right Dix Hall pipe, that's the opposite, because that's talking about slow phase. And when we talk about BPPV nystagmus, we're defining it by the fast phase. So we're going to look into this a little bit more. So here's some questions that somebody typed in. Clarify overview of BPPV. It was specific to the slide and the different canal involvement in lesson 6. Please clarify arm of canal away, near, types, canal, cupula, short arm. So I'm going to show you a picture of this. I've seen other terminology, anterior, posterior arm. Does this apply mainly to the horizontal canals? We're going to talk about that. Does anterior equal ampullary, posterior, non-ampullary? So let's look at a picture. And then we'll do that little exercise where we think about where the ampulla may be. And I brought some pictures and some models as well for that. Sorry, I'm moving some screens around. So in this picture, this is a picture that shows all the different types. When I think about this picture, I made this for the download. You should have seen me trying to draw all the little dots. It was like, took forever. I think about when patients self-treat. That's what I think when I see this picture. It's like, maybe we should do a patient education handout on self-treatments. I'm not like overly opposed to it, but the thing is that it really, the literature varies on the occurrence, but we all kind of know that it's primarily in the posterior canal is the most common canal. So the Epley maneuver will typically work, but there's all these other types that can have, and that's when usually the Epley doesn't work. So if you can see my little mouse here, I'm not sure if you can see my mouse. There we go. So posterior canal, ampullary. So here's the ampulla, posterior canal. The non-ampullary is when it's thought that they're kind of stuck over here in this area in the non-ampullary posterior canal. They can be stuck to the cupula for posterior cupulolithiasis. There's this theory of short arm where it's thought that this probably only occurs in the posterior canal. So the short arm, this was described by Michael Schubert, Dr. Schubert, in an interview. It was a vestibular SIG, APTA vestibular SIG podcast. I think he was interviewed about type 2 BPPV, which is kind of in that short arm. And he said, think of a billiards or pool table, and you have the pockets. He said, think of like the otoconia, like when the balls are in those pockets, they're there, but they're not enough to have an effect on the cupula. So if we're thinking they fall off, they're free floating, and they can get kind of caught in this short arm. And that's what is thought about type 2 short arm BPPV. We look in the horizontal, this is where the ampulla is. So the ampullary side, the non-ampullary side, anterior canal, ampullary, non-ampullary. So this is a model. From vestibular first, I know I have some blur effects going on to block out all the stuff on the whiteboard, but this is from a model from vestibular first that we use here in the clinic. This is an ear, this is all going to be blurry, but this is a picture that we use in all the rooms that can show people the inner ear, but we all also like to utilize the model as well to give them an idea of like, what are we doing here? Where could these otoconia potentially be? So we've got the different on the horizontal canal. So everybody, if you'll just go like this, you don't have to turn your video on, but if you want to, you can just put your arms out like this, put your fists together, and think of this as the horizontal canal. Your horizontal canal. This is the ampulla. This is the ampulla. So this is the ampullary side. So this part of your arm is anterior. This part back here is posterior. So when we talk about the anterior arm, this was a question asked on previous slide, and the posterior arm, that's talking about the horizontal canal. So you can just think like this. This is the ampulla. This is, in our minds, this is anterior, this is posterior. So this is on the ampullary, anterior arm, posterior, non-ampullary arm. Does that make sense? So when you think about where the otoconia may be, if they're in the anterior arm, on the ampulla side, in the ampullary side, in the horizontal canal, or maybe you think utricle side, because the utricle's on the other side, utricle, ampulla. If you think someone's like, here's the canal, and there's otoconia in the anterior arm, what we're going to talk about is when they roll over in the horizontal canal, and they're moving away from the ampulla, and that's going to cause a certain nystagmus, or towards the ampulla. It's going to be inhibitory, excitatory. That's where Ewald's law comes in. And we'll be reviewing that. Okay. So this is a table that I had mentioned. Can't remember if it was in the key concepts, but someone had reached out that you couldn't find it in supplemental materials. So I will make sure that this is in supplemental materials, because as we moved platforms, some things didn't get moved over. So I'll just go through this. It's an Excel spreadsheet that we're going to look at ampullary posterior canal. And what this, I won't read through this because it'll take forever. Just want to show you how this particular table works. It shows, okay, because we're all different types of learners, and this breaks it down to right, left side. So if it's in the ampullary and you're in a Dix-Hall pike, we expect this upbeating, this torsion towards the undermost ear, and in the left, it's upbeating and towards the undermost. What I'm going to make some comments about some different things regarding this chart is you see the words counterclockwise and clockwise. So just remember, when you see upbeating and torsion, so it's an upbeating in a right Dix-Hall pike. So this is the right ear. I've turned the head right. Can turn the head right. What we're doing is trying to get that posterior canal more perpendicular to the ground to get the otoconia moving, get a better response, right? The patient may not like that, but it helps us. So they're going to be moving in the vertical away from the ampulla. And there's, this is the right side. So when we see that type of nystagmus, that type of describing nystagmus, we're talking about the fast phase. When you see the words clockwise or counterclockwise, it's what you, the observer, are seeing. It's what the observer sees. So if you're looking at a patient, let's say we think about someone in a right Dix-Hall pike, we bring them down, we see the upbeating and torsion towards, if it's right posterior canal, towards that right ear, it's going to look opposite to us. It's towards their upbeat. It's upbeat and towards their undermost ear if we're facing them. For us, looking at it, what we see, it's counterclockwise in a right, and it's clockwise in a left. So when you see counterclockwise and clockwise, it's the observer's perspective of the nystagmus. And he's making a comment, vestibular first also makes life-size models, and patients love to see how tiny it actually is. Yes, they do. They can't believe it. Thanks for bringing that up. And I don't have it here, but they also have it that you can wear on the head, and it has little as a right and a left, which is a great teaching model as well. So this is the way this chart works. It just walks you through posterior, apogeotropic posterior canal, which when they're on the non-ampullary side, what you would see in a right, what you would see in a left Dix-Hall pike, posterior short arm. We don't see the nystagmus in posterior short arm, but positive symptoms. And then the diagnostic criteria is when they sit up, there's truncal sway. Now there's a couple of kind of big articles on type 2 BPPV. They're in the supplemental materials. It shows anywhere from a 40 to right around 50% occurrence of this type 2 BPPV or short arm in clinical settings. We don't see that kind of volume, that kind of percentage, but we definitely are doing treatments. So just a couple of things to hear when you think about BPPV on the ampullary side, posterior canal, most common. To me, if you can remember one direction and what's the most common canal, what is the most common type of BPPV, if someone wants to type it in, that we see. I'm going to pull the chat up so I can see it. What's the most common type of BPPV that we see? Ampullary, thanks, Katie. Yes, posterior canal, thank you all. So upbeating and torsional towards that undermost ear, ampullary side. So if it's on the non-ampullary side, what's the direction going to be? If you can remember one, the most common, how do you remember it when it's on the opposite? It's downbeating because it's opposite. And if there is torsion instead of towards, it's away. So I mean, you can learn this and remember this how you want. But I do try to keep things, I don't sound simple all the time, and I apologize for that. But I like to think, okay, it's usually in the posterior canal on the ampullary side. It's upbeating, it's torsional towards the undermost ear, the affected ear. What's it going to be like when it's on the opposite side? So, and yes, thank you. So this is just walking you through different, different types. Anterior canal, it can be difficult to differentiate between, this was a question actually from a participant. How do I know? It can be tough to differentiate apogeotropic posterior canal and down anterior canal. In anterior canal, the down beating is most prevalent, and the rotation will be towards the affected ear. The straight head hanging test is the best test for anterior canal. And so on anterior canal, it can be positive in both hall pikes, both Dick's hall pikes. Just remember, straight head hanging is the best test for anterior canal, and I'm going to talk about what the research shows right now is the best treatment. So the best treatment right now, it doesn't matter if you know which side. So we'll get to that. So I just wanted to show you this, adding this to your supporting materials. I already thought it was there. I think what happened is I updated it maybe because I added posterior short arm and then ended up not uploading it back into supplemental materials. So that's how that breaks that down. We'll move on to horizontal. We've already done this little, thinking about the canals. So if we think about the top picture, A is the middle picture. So the X represents the left ear. And so that's where the otoconia in the posterior arm, they're in that posterior arm. Let's see, the utricle ampulla, yep. And then when you turn the head to the left, it just shows where the otoconia are going to move. And it's going to be excitatory because it's in the horizontal canal moving towards the ampulla. So this goes back to Ewald's law. When we go to the opposite side, it's going to cause an inhibitory response. So when it's in the posterior arm, and this example is talking about left, and we think about turning the head left. So we bring it in flexion, turn the head left, and they move towards the ampulla. What type of nystagmus, what's the direction of the nystagmus going to be? Geotropic or apogeotropic? For posterior arm, excitatory, geo. Excellent. And in the geo, so when I go left, geo is going to be towards the ground. I go to the right, it's going to be towards the ground. In geotropic, posterior canal, horizontal canalithiasis, posterior arm, horizontal canalithiasis. How do you determine the affected side? You can test it through the bow and lean. Yep. If you're not sure, stronger. So the bow and lean is not a test to identify, just as a reminder, to identify horizontal canal. It's a test, just like Jen mentions, if you're not sure which side, you can perform the bow and lean test. But it will be stronger on the affected side. So if I have geotropic nystagmus, I go left, it's excitatory. I don't know. When I turn someone left, I don't know yet. I have to turn someone right to see what happens. If that's like I see it again, a transient geotropic, but it's weaker, That's consistent with posterior arm horizontal canal lithiasis. What if I turn someone left and it's in the anterior arm? And now it's going to be moving away from the ampulla. It's going to cause apogeotropic, also ageotropic. Those are the same. Apo and ageotropic are the same. And it's weaker on the left, but it's stronger. The intensity is stronger when I go to the right. Which ear is affected in apogeotropic? The weaker side, the one with the weaker intensity nystagmus. Excellent. And so this is the question is, thanks. This was a question, how do I tell the difference in anterior arm canal lithiasis or cupulithiasis? What are your thoughts? What would be a differential in anterior where you get apogeotropic, bilateral apogeotropic? Phil, excellent. Short versus long duration. Yes, Lisa. Yes, Katie. Yes, Jen. Perfect. It's the duration of the nystagmus. Excellent. And then also on this, just want to show it does on the bow and lean. So in a geotropic, the right beating in the bow, the left beating in the lean. So it has this on there in the chart as well. This was a quiz question. The quiz question, how was it worded? It was the more intense fast phase beats towards the affected side, whether it's geotropic or abeotropic. True. I don't ask true or false, but maybe I did. I shouldn't ask true or false questions. Those are horrible test questions. I think I had it in a sentence. So let me ask you the question. When we test for horizontal canal, and we go to the right, and we'll stick with this example. We go to the left, and let's go back to the posterior arm involvement, geotropic, the side with the stronger nystagmus is the involved side. And then the weaker intensity nystagmus. So when I'm here and I turn left, it's stronger geotropic on my left. It's more intense nystagmus, which means the fast phase is more intense, correct? Is that fair enough to say? Okay, and then, so when I go, it's like a fast. I roll over. It's not, the fast phase is like, it's not as intense. The intensity of the nystagmus or the fast phase. Okay, agree upon that. Let's go to anterior arm. I go left. It's like beep, 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 going beep, beep, right? It's like up, 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 up. We don't know. You roll me right. It goes apo, fast, like more intense. So the fast phase, that more intense fast phase beats towards the affected ear, whether it's geotropic or apogeotropic nystagmus. Does that make sense? Okay, because it can be super confusing. If that confuses you on the side, you can some people, like for me, I don't do the bow and lean. And Annie, I think you asked a question on the bow and lean. I think it was you. I didn't mean to, I meant to scroll on the chat. You ask a question, what percentage of the time do you see the nystagmus with bow and lean? I don't use it that often. I mean, I would say when I've used it, I see it. It's certainly easier to see when you can record it with goggles, but I don't know if there's an actual percentage, like an article on the percentage, but I know it's consistently relied upon as a differential to identify the canal. I'm not sure if that answered your question at all. Let me go back up.
Yeah,
I see.
oftentimes I won't see it, but then I'll treat them for horizontal canal BPPV and it will resolve. And
You don't see it in,
with
like,
with the
let's say you
infrared
do a
video
roll,
goggles.
if you do
Yeah.
a roll test and you're not sure which side to treat, so you do the bow and lean,
Mm-hmm.
and then you don't necessarily see it in the bow and lean.
Right. And I've heard a lot of other people say that maybe just the way that orientation of people's canals, or I don't know,
Yeah.
because it seems like
I
regardless, you'd get it with bow and
yeah,
lean.
I don't even know the last time I used the bow and lean. For some reason, focusing on the intensity of the fast phase is kind of what I rely on. But I don't, I know y'all have probably seen such intense nystagmus with people, especially in horizontal canal. Uh, Sometimes they just don't want to open their eyes because they're going to get really, 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 really sick. Uh, but I personally have not used the bow and lean in some time. I see there's a message, so maybe someone's adding on the bow and lean. Oh, Terry's like 80% of the time. But that's an interesting question to see if there is research on how common it's seen. It's a great question. Okay. This is a slide just to show you again. Thank you for your patience on letting me move some slides around. I took this picture from one of the articles that you have in supplemental materials. And then, so this picture on the top is showing the ampullary arm of the posterior canal. This is showing ampullary arm of the anterior canal. And then this slide was showing non-ampullary arm of posterior. So we have ampullary, non-ampullary. We have now in the ampullary of the anterior canal. We don't really talk about non-ampullary of the anterior canal because if it's over on this side, it's just going to fall. It's either, some show that it can go in the posterior canal, but gravity's just going to pull that down. So that's why we don't talk about non-ampullary anterior canal. So then it talks about with this head hanging, what happens? Well, in the anterior canal, which is a vertical canal, we get the oticonium moving away from the ampulla, which is going to be excitatory. Posterior, also a vertical canal. If it's in near the ampulla, it's going to be moving away, causing excitation. If it's in the non-ampullary, it's going to be causing inhibition because it's moving towards. So that just gives you an idea of where those oticonium may be moving in the different types of canal involvement. Leanne asked a question, and then we have Paige saying she's curious as well. Do you ever get a positive roll test on one side, but not the other? Do you assume then? I don't assume. We know what happens if I assume. Then you're not seeing BPPV. It's a great question. If it's transient, and I don't see a difference in using Frenzels, not using Frenzels, I kind of think it's BPPV. It's just not presenting. And I do later give you an article that talks about atypical presentations. And what I like about that article is they have two tables in there that summarize atypical types of horizontal canal and the theories of why you might not see it or why you might not even see it change directions because now it looks direction fixed. So I oftentimes come back to this, is it transient classic symptoms of BPPV I don't hang my hat on that 100%. But when it has a little bit of a latency, thinking that gives it time for the otoconia when it's transient, I do think it's still BPPV. But then I may be doing differentials like repeating the test 2, 3, 4 times. But I'll also, like, we have these in each, yes, we have a V&G system, but we have these little frenzels that have a light, and then I'll use these to see if there's any difference with like a spontaneous. But I think you can see BPPV just on one side. Can you have a latency with onset of nystagmus on one side but not the other? That's a great question. I mean, I think you're typically going to see latency because they need a little bit of time, unless it's cupulolithiasis. That is questionable of whether there will be a latency in cupulolithiasis because, the cupula is deflected pretty immediately. Certainly with canal lithiasis, I do expect to see that latency. When I don't see a latency, it makes me like, whoa. Or if I start to see a nystagmus before I get like a cupula, anything that would be moving, I'm like, whoa, that happened really early. So I'm not saying it's not BPPV, but it's starting to have an atypical response. With horizontal canal, if there's no latency and it doesn't fatigue, it's probably not BPPV. And we might be thinking about, and I mean, yes, it could be horizontal canal cupulolithiasis. I can't, but we may start looking, is there a null point? And we're going to talk about light and heavy cupula. Now, for those of you in the CCVR, I did give you a warning that this was probably going to go over 8. So, and checking to see how it responds to light fixation. Absolutely. Absolutely. Okay. I haven't even gotten to all the questions. So this again, just some recommended maneuvers. I'm going to come back and touch base on this again, based on some of the more recent research. We can do the Yakovino, the modified, the liberatory, quick liberatory, reverse Epley. It is agreed upon the straight head hanging is the best test. Don't forget about the loaded Dix-Hallpike. I like the loaded Dix-Hallpike test. Now, if you have someone with, you don't, it doesn't mean you have to do it with everyone. If someone's coming in like, oh my gosh, don't do that, I can't stand it, they may be having strong responses already. And so when you do a loaded Dix-Hallpike, which is going to give you the best results, which may mean more intense results, because you're putting them in flexion, kind of loading the otoconia, and then taking them back, and that helps them move more in the middle of the canal, where you're going to get the strongest response. Then that means the strongest response is good for you, not so good maybe for the patient, because it's going to be more intense vertigo. But I do love the loaded Dix-Hallpike. I like the towel. I like the pillow, because especially if people are just adamant about doing self maneuvers when they come in, they're like, okay, I'm going to do this when it comes back. I'm like, okay, I give them a handout on this. Like, don't hang your head off the table. I had this conversation with someone today who does self-treatments, who actually had non-ampullary posterior canal BPPV. And she said the Epley helped, but it didn't help with everything. So I ended up doing a demi-cement on her twice, retested her, and I actually converted her to the ampullary side, which then I did the Epley because it did change to upbeating. And so she's like, okay, well, I'll just do the Epley at home. Well, she also lives a really far distance. So I said, I don't want you hanging your head off the table. And so put the pillow, because what I love about the pillow, it gives them the extension without hanging their head. And when they roll and then roll off the pillow, it gives them kind of that added chin tuck. So I do like this picture of the loaded Dix Hall pipe with the pillow behind her back. So this research, this article you have in supplemental material is recommending the modified. And so the modified is supine with extension, and you don't need the 60 degrees. You don't even need that much extension. You leave out the flexion, the supine with cervical flexion. So you go from supine with extension up to sitting, and then cervical flexion. And this article looked at the different maneuvers and compared. And the modified showed a decrease, converting it into the posterior canal. The other thing I like about this article, and I show you, is here. Sometimes, when we're doing online, the video doesn't play as well. You don't see it as well, but let me play this. So they're in long sitting. They don't tend to have tight hamstrings, which is nice. So you can see here, they're not in the 60 degrees extension, just the 30. And it's showing this videos that they have where links from the article. You can access these videos. It shows where they move to this part of the canal and then sit up, and you're waiting them to move for the second half of that canal. So this is showing the otoconia moving. And then it shows, okay, let's flex the head to get that final, they don't show the flexion here, but then get that final drop. There it goes. And then the flexion. But the other videos that you see here, they'll also show, whoops, over here on this side, sorry. I don't have these as videos, but in the article, you can link to the videos, and it shows you with each of these where the otoconia are moving. And with the standard maneuver, there is a little bit of a higher risk for it to go into the posterior canal, which is no problem. You can do the epley, but that's why the modified version. And so it compares the short or the quick liberatory. It compares the right, the epley using what we call a reverse epley. So if someone has left anterior canal, you do a right epley. And I like the links to these videos with that article. So I just wanted to highlight that. Type 2, this is another form. This is what I talked about earlier. This is when it's thought to be in the short arm. It's in this particular article, it showed to occur 50 or greater or more % of the time in a large, balanced center where they were seeing large numbers of BPPV. So this is when someone comes in, sounds like it, then it sounds so classic. And then you test them, and when they lie back, you don't get anything. But they get the subjective, and it's on that effect, what side they think it's worse. Like, it's worse when I roll over to my right. You go back, and they're like, oh, there it is. And they may have like, oh, yes, I have it. And you don't see anything. Then you can sit them up, and you look for this big truncal sway. That is the diagnostic criteria for BPPV. Now, this can, I get that, can kind of open up a whole bag of worms here, because we do know that the older population from the research may not have as strong of a response. Now, some older adults have really strong responses. They hate being tested for BPPV. So it's, if you can take them back, and then if you want to complete the Dix Hall pike, then bring them up into sitting and see what happens with truncal sway. And here it's repeated sit-ups. So can your patient do that? So they go into the right Dix Hall pike, wait for their symptoms, come up, go back, come up. So, are your patients going to be able to do that? There's also this maneuver, which I should have shown the video, because the video available for this is it does have some shows really violent shaking of the head. which I have not tried. I have not tried this maneuver on anyone, but you can. There is now a video that you can see how this particular treatment for short arm is done. We utilize repeated sit-ups for patients. They do 10. They do every day for a week. And Terry's sharing, she has them do 10. Annie's sharing, she has them do 3 times a day. And so that particular recommendations are the ones that came from the previous article. Oh, you don't. That's just what the article said. Yeah, we usually have them do them once, maybe twice a day.
Yeah. Do you have them wait 30 seconds after their symptoms stop before they sit up?
At least 10.
At least 10 seconds? Okay.
Yeah. Yeah. This was another, Dr. Helminski did, uploaded this article about, she shared some case examples on short arm posterior canal. Pretty intense article. So a good one to keep in your back pocket. I love the pictures that were in this article showing where they may be. PC, like LA, is posterior canal long arm. Then you've got the utricle. Then you've got the, posterior canal short arm. But she shows where they could be in different places, which I really like. So posterior canal short arm, posterior canal long arm. It's proposed that this is where on the non-ampullary side, so NPC is non-ampullary posterior canal. Really great pictures in this article. This is just, showing you the Gaffani. You can use the log roll. You can use for horizontal canal lithiasis, geotropic, the 270, the 360, the Gaffani, or the modified Zuma. You can also use, well, the Lee maneuver should be on there as well. You can use that. Jake says, when I had a couple of patients like this, they needed help to sit up or they would have fallen over. How do you do it at home? I mean, certainly I would only have patients do it at home if I thought they could do it, do so safely. Some patients don't have the core strength to do this at home. If they're doing this, would be interesting. Like if I'm thinking of someone doing this in bed, I haven't seen so much truncal sway if someone was in the middle of the bed that they would fall over. And I guess maybe having them do it with someone if they could, but I know that's not always the case. So if someone we didn't feel comfortable with doing at home, I mean, we would probably try in the clinic some repeated helping them. And I guess someday I may have to go ahead and do the deep head hanging one with a bunch of rapid head movements. I haven't tried it yet. The modified Zuma for geotropic, the Zuma is known originally for apogeotropic horizontal canal. I'm a creature of habit. I have a tendency to do the log roll. If, I like the Gaffani for geotropic. So let's say I do an entire log roll, or I have someone and I'm thinking, okay, it's this side. I'm going to kind of just take them into a Gaffani and end up doing the nose down. Or when I do another treatment, I may choose the Gaffani. So I make those choices usually on their mobility. The Lee maneuver is actually even less steps than the Gaffani. And so I have some information on that as well. The log roll for APO, you can do the modified Gaffani, you can do the Zuma. This was an article by Ramos and colleagues who talked about different types of like anterior arm, different proposals of how this could present. And so this is interesting. These are the articles I kind of go back to when I'm not seeing what I thought I would see. This picture on the right, this is for, for those of you that have the membership in 360 NeuroHealth. Well, I say 360 NeuroGo, then, all don't forget about on the side for premium or enterprise memberships, we do have the assessments where you can watch a video and then it has, like all the pictures, like the pictures you just saw came, they were utilized for BPPV treatments and assessments. I do not have the Lee maneuver in there. I need to add that. So these are just the steps on the Lee maneuver, and I've uploaded this into supplemental materials as well. The Kurtzer hybrid maneuver, I would love if anyone on this coaching call has done it. This was proposed to combine kind of everything that all variants of horizontal canal could be treated in a maximum of 4 positions. So you have this article in supplemental materials, but I have not performed this. I was trying to there's an audiologist that teaches on this in the GANS or American Balance, not American Balance Society, not ABS, I'm thinking of American Balance Society, American Balance Institute. He specifically teaches on this. Okay, so Bethany has done this with a few good results. So thanks for sharing that. Oh, I had to throw in one more reference. This is a go-to article that we utilize in the clinic. These are modified interpretations. So this goes back to your earlier question of, what if I only see it on one side? And you can see on some of these, it shows that you may not see nystagmus on one side. So if I'm seeing something atypical, this is my go-to article. And Jackie shares that she's used the horizontal hybrid and has had success with it too. Great. Okay, here we go. Now we're gonna marathon it. Some questions. Null point refers to a point where you turn the head and it seizes nystagmus. So that is something used in light cupula and heavy cupula. If you have a patient, it's also used a null point, not just in BPPV, but if you have someone with congenital nystagmus and you have them smooth pursuit, it'll increase the nystagmus, but oftentimes you can find a null point where that nystagmus. So it's where the nystagmus stops. And so in light and heavy cupula, this is a differential. During anterior arm canalithasis with the Gaffani is anterior canalithasis with the modified. Is it expected the anterior arm will go posterior arm? So it was theorized that it could happen with when you're using the Gaffani or the modified, so instead of nose down, it's nose up, that you could put it to the posterior arm. It's possible. That's where the Zuma maneuver became the recommended maneuver over that, was to decrease the chance for that. Do you treat in the same session or wait till the next? That depends on, horizontal canal is a little tricky. It depends on how nauseated they are and how much time we may have, but we're going to talk about repeated maneuvers. 48-hour precautions, you don't need to. The literature suggests that it doesn't make that much of a significant difference. I'm somewhat of a creature of habit and still give precautions, but not as strict. No, you don't have to sleep up in a chair. When we used to put a collar on people. Don't do that anymore. But, hey, I'd like you, maybe not to go to yoga. Hopefully you're not getting your hair done. Don't want the head hanging. So we do I do, not everyone in the clinic. Some of the therapists don't give precautions. I have a tendency to, we still have them on our handout, but like the main thing is I also want people to sleep. So if they're like, well, that's the only way I can sleep. If I don't, I can't wear my CPAP. Well, okay, just sleep that way and wear your CPAP. I don't want them not going with their CPAP. So I'm certainly not as much of a stickler. Is there anything I can do to prevent it from transitioning? Historically, it's thought like in the epi, you could add the chin tuck to decrease the risk. You know, there's been an article that said wait 10 minutes. I'm going to bring up this again because there's other articles that say 2 minutes is enough. So just waiting before you retest. I'm confused of how the posterior canal is so commonly affected. Can't really show on this. If you think about that picture, the earlier picture I showed you with all the different types. So basically they're on in the utricle, the otoconia get dislodged and gravity kind of pulls them down. And then when someone lies down, the position of the posterior canal and then rolls over or sits up, it's the canal that's the easiest for them to be thrown into. You can see how it would be difficult on the anterior canal. And then it can potentially go in the horizontal canal. Annie, also for the third question about the PC, the apex is 20 plus degrees below horizontal. Yes, and so that's why the position of the canal is why it's thought it's easier versus, you know, it's not perfect, but like the horizontal canal is 30 degrees. The anterior canal we know sits up here. So it is thought that it's easier to fall in that posterior canal for that very reason. Thanks. Thanks for the ad. Do you just do one maneuver? I usually do repeated. Repeated maneuvers just depends again how much they tolerate, how much time that we have. How do you bill? So we use the canalith repositioning code the CPT code for that. It is not a timed code. So if you spend 40 minutes testing someone or treating someone, you can only use that code once. So we'll use it once, but then we show pictures, we go over patient education, we maybe go over ADL modifications to decrease the, you know, in case we're not sure if it's cleared. And so that may be some ADL. Maybe you do want to give them a couple of exercises while, you know, that you feel that BPPV that's not going to interfere with. So we do add other treatment codes because we're usually spending 45 minutes with these patients particularly if it's complicated, but we're only using the canalith repositioning for one time. It has become a little tricky. Blue Cross Blue Shield is going through a little period with us, not this, but for everybody, where they're not paying for BPPV or dizziness, any treatments for that. So that's been a little difficult for us. So we're just doing, you know, and if people come in, we'll, you know, usually we can do some high level balance testing or it's affected their walking with head movements. And so we're using gait dysfunction or unsteadiness for their primary, secondary diagnosis, and then their BPPV as that third diagnosis, because they usually don't go by the third. They consider the 1 and 2. So that's been a little tricky, which is unfortunate. One maneuver, how do you bill? Canal versus, you can't really tell. No clear way to determine, even though in the Dr. Ramos article that I mentioned, it was mentioned that there's some possible differentials in there. Do you have to have nystagmus to truly have BPPV? No. And that was my do they have truncal sway? Or is this potentially someone with a reduced overall response? Sometimes it's harder to move people more quickly. That's why I love the loaded Dix Hall pike. And then, you know, you're trying to get the otoconia, the more they can move in the middle of the canal, the stronger the nystagmus. So first I'd be like, well, how well could I move this person? Or is it potentially type 2 BPPV?
And with the sway with type 2, it can also just be straight up truncal retropulsion.
Yep.
Correct?
Uh-huh. Mm-hmm. My fruit drink there. Okay, let's see. Some people have vestibular neuritis, have BPPV, others do not. Why does BPPV recur in some but not in others? Physiology behind vestibular neuritis causing the otoconia. It's not completely understood. So I just listed, there's, some studies, 10% recurrence rate of BPPV in those with secondary BPV associated, and more complicated. So people who have vestibular neuritis and secondary BPPV have a tendency to have a more difficult time resolving the BPPV, and a higher, it comes back quickly. So the literature varies, but so let's say around 30% in the first year. It goes up to by year 3, 50% or greater recurrence. It does seem to be more difficult to resolve. And then another study looked at clinical features in vestibular neuritis, found the following: lower age, posterior canal is the most prevalent, the presence of hypofunction, and more difficult to resolve at higher recurrence rates. So it's not completely understood. It's just an inflammatory response. The superior nerve branch is the one most involved, spares the posterior canal. But if it spares it, why is it involved? Then it's thought just an overall inflammatory response is causing that. Should I repeat testing? If you really think someone has it and you're not sure, yeah, you can repeat testing 2 to 4 times. I'm not going to repeat it if I get what I'm looking for, but if I don't get what I'm looking for, I may not start with the loaded Dix-Hall pike because I'm not sure how they're going to respond. And if I don't get it, I go back and say, okay, let's start here and bring them back. And then we talked about repeated CRMs. These are just some overall recommendations. Loaded Dix-Hall pike, think about the speed of the movement, how it affects the debris and the canal. Repeat the test 2 or 4 times. I don't expect you to read these others. These are screenshots from What's on Your Mind. Remember, if you're in 360 NeuroGo, and you can go up at the top and there's a search button and you can type in BPPV, you can type in repeated maneuvers, you can, MDDS, whatever. It's going to bring post, shared comments, research articles. It'll bring those up once they've actually been mentioned somewhere within 360 NeuroGo. So this is from Blair Graham, physiotherapist in Canada, who's very active in responding in What's on Your Mind, and actually provided 3 different research articles because someone posted this question within What's on Your Mind. Talked about, this is the article that I was referring to earlier, mentioned a 10-minute break, but others, basically, another one said 5 minutes up to 10 maneuvers, and then saved, I think he mentioned he saved the best for last, and this other article, and he broke down the findings of this article as well. And they recommend 2 minutes, less than 2 minutes between completing the maneuver and retesting. They looked at 44 patients. He broke down what the study found and kind of his final kind of take-home message after each person did test negative. So they repeated within 2 minutes after each person finally did test negative. They waited 15 minutes and then they retested them again at 15 minutes, and nobody had a recurrence rate of BPPV at that point. And their conclusion was to perform repeated maneuvers in one session, less than 2-minute breaks between. But if you convert a canal, go ahead and treat it immediately. So if you're treated a posterior canal and you go back and take them into a Hall pike, and even though you're not in a roll test, you're probably going to see a horizontal nystagmus. If you've done a canal conversion, it'll be pretty strong, even in a Dix-Hall pike. Then you can be like, okay, look to see if it's geotropic, apogeotropic, and then you can, hopefully they don't get sick, and you can go ahead and treat that. Okay, your turn. I know it's past time. I'm going to bring up the chat because I haven't been able to see it.
Bridget, I had a question.
Yes,
And I kind of not sure how to write it out, so I'm just gonna talk it through if that's okay.
sure.
Um, so I'm having trouble understanding certain elements of this conversation. But in ordinary settings without autoconia that's displaced, you turn your head, that causes endolymphatic flow, right?
So we're not talking BPPV?
Right, yeah.
Okay.
Ordinary, yeah, so you turn your head, there's a movement of the fluid that sends signals to the vestibular nerves, which sends signals to your brain about what's happening,
Mm-hmm.
and there's no nystagmus. But then in the setting of displaced autoconia, the autoconia is moving in conjunction with the head movement, which causes endolymphatic flow. Is the problem there because the autoconia weighs a certain weight? It's causing the flow to be different, so it's sending prolonged signals to the brain, and that's what causes the nystagmus?
Well, it's still causing a deflection of the cupula. So can you see this very well?
Yeah, I can see it.
So normally the endolymph and the cupula have the same specific gravity. But now there's otoconia in there, not having too much an effect when they're just hanging against the canal wall. And then when you move someone and they begin to move, there's a little bit of a delay, and think of it maybe as like a viscous drag. So it's like a delay and then boom, they start to move and have an effect on the cupula.
So
Because
you're not
of,
moving at that point anymore. It's a
no,
delayed response.
it's a delayed because they're here and then they lie back and then they start to move, which causes the latency and it
Right.
causes a viscous drag. And the heavier the weight, the heavier the deflection on the cupula, the more nystagmus you're going to see. And then gravity settles it down and no longer has an effect on the cupula. So it's a structural change affecting the viscous drag versus a physiological asymmetry that happens with like acute onset of vertigo. Does that make sense?
Yeah, that makes sense. I think I'm just trying to piece together like why is the response nystagmus exactly? Like why is that the consequence?
Because it's having an effect on the cupula, like an excitatory and inhibitory response. So if each canal, we have each canal innervates different or talks to, results in different eye movements.
Right.
And there's excitatory and inhibitory. So there's what happens to this eye on the same side and on the contralateral side. That's how we get conjugate gaze and eye movements. That is a normal vestibular response. But what happens with BPPV is a structural abnormality. It's still stimulating the cupula, still
Right.
stimulating, or it's either excitatory inhibitory response. So it's still having that kind of eye movement. It's just caused from a kind of a mechanical problem. It's versus a normal physiological response that we want when we move our head in certain directions.
Right. That makes sense. Thank
Okay.
you.
And I'm sure someone out there is like, gosh, Bridget, you could have explained that way easier and
No, that was perfect. Thank you.
okay. And I look forward to meeting you, Jacob, face to face.
Oh, yes. Me too.
Jen, I have difficulty when you've treated BPPV, no longer seen nystagmus, and patient still reports fleeting vertigo that could be motion sensitive. Do you have a good way of determining what's motion sensitive? Mainly self-report, not true reasoning. Hope that, yeah, that makes sense. I see it. I think we see that all pretty frequently. So someone comes in with BPPV, we treat them, we think it's resolved, and we're like, okay. And even on the handout, it says you may not feel well today. You know, you may feel a little unsteady. So after I've treated someone, I like to get up, walk around, see how they feel. You know, tomorrow you should feel better. Now, I'm still wanting you to be a little cautious, gradually get into your normal activities, start moving around, and then we tell them, like, well, within a week of you returning, you no longer have positional vertigo, you start to get back into your activities. Within a week, I expect that you won't have residual symptoms. So first, we do an exam. If and we test balance. It's question. I do DVA testing most of the time with BPPV, even though I don't know how reliable it is, because I have to think that the otoconia in the canal could affect VOR, because the endolymph and the cupula, they don't have the same specific gravity anymore. Anyway, I think that VOR is probably could be affected. So if there's other things, then I'm having them come back to address, and I'm like, okay, well, when you come back in a week, we're going to retest the BPPV. I want to retest your balance. I'm going to do a couple of other tests I didn't do today, and then we address those. If someone comes in just with BPPV, unicorn, posterior canal, you did one treatment, this is like the best ever, and I just let them know that it may be you've had this a while, that over the next week, you may have residual symptoms, but as you get up and move around, your ear recalibrates itself, then you should have no residual. And don't let them settle for, well, at least it's not that bad, positional. This, now I just fell off. Like, I want you to come back if you have any residual symptoms. I think the brain can remember, and some people are afraid. So they're so afraid that when they go back, they feel like it's going to happen. Oh, I feel like it's going to happen. I'm like, your brain will start just to trust it. It's not happening. Just take some deep breaths. It's not happening. And if needed, we'll go to habituation, where they just practice getting back, rolling over, and realizing that it is not going to happen. Annie, can you please share the handout you give to patients, status posterior, mentioning how they might feel it can take the brain 7 days after successfully? Yeah, can share that. I'll upload it into CCVR into the lesson 6. What else do you do for light or heavy cupula? Nothing. It's not considered treatable. So I have seen patients that come in with this geotropic, non-fatiguing, direction changing, horizontal canal, roll test, pine roll test, geotropic, or maybe it's apogeotropic. It's not fatiguing. There's no latency. Maybe I can find that null point, and then they come back 3 days later and now it's switched. And then usually that ideally goes away. There's not a lot of literature on light and heavy cupula, and the number of patients are low. It is considered most of the time to be a central cause. And usually there's abnormal ocular motor associated with that. But it is a little controversial, the light and heavy cupula, but we think we don't treat it. We just see what happens. Anything else? They're like, no,
Bridget,
no one.
can I ask the audience a question? I was just curious how many hours before the coaching call in a dream world they would get the handouts.
Well, see, that's going to be up to you now.
That's why I wanted to ask the audience to see what their hopes were, to see if I might be able to oblige. Okay, I see Aisling say just before. Well, that's a good point. It makes it easier with printing so people can write notes on there. Okay, cool. Thanks, guys, for responding.
And Barb, for those of you not coming to Austin, I am going to be releasing some information. First, what I'm going to push is that if you can't come to Austin, that you attend virtually on the same day we do the live. So I'll have a video, I'll have things set up here where we'll be for those. So that's May the 4th. And we'll be reviewing the techniques and then people can practice. So you'll get the chance to like, you can see us review the different parts of the lab, and then we break people off into groups and we check people off. And for those virtually, we'll be doing that in a separate room, breaking you into rooms. That's ideal because there's so many taking CCVR that to do everyone in after it's just going to be first come, first serve. What kind of time bandwidth do we have? So I will be pushing as many people as possible to even virtually to attend that same day. And if you can't, we're just going to have to figure out times between people who can, instructors who can help with labs and what times they have available. Like for me, I'll make Tuesday nights available and Thursday nights available. Because I won't be teaching CCVR and our advanced course will be over. But like I see patients 4 days a week, so it'll be real tough for me during the daytime to do any labs. So we're going to really push people to even virtually to attend that same day on May 4th. May the 4th be with you. But I'll be pushing that out in CCVR. So pushing that everyone attends even virtually the May 4th, and those who can't will be first come, first serve as we find available slots. Yay. Thank you all so much for your patience, especially going this late. I hope this was of help. And I think BPPV, we see a lot of complicated things, and this is the beauty of, hopefully we create this community where we can help each other. Terry has, not just Terry, but I know Terry's been posting some videos and getting different perspectives of what people see. So that's awesome too. All right, we'll see you next week, and welcome Annie. Thank you so much. Look forward to you being consistently involved in the next CCVR launch.
Thank you. I'm so excited. Have a good week, everyone.
All right, y'all have a good week.